Good evening. Time for another Ask Me Anything. So I hope you guys are having a great week. I'm trying to rock some new blue blockers. Got a pair from my favorite blue blocking company, EMR Tek. Usually wear my Wolverines more than most of the day, but I want to try to see how these work for the rest of the evening. So we'll fire up some questions and get started here. So is it okay to have coffee if you have known heart disease? It's a big old depends. Depends on if you have palpitations, issues with sleep, blood pressure issues. There's a test called CYP1A2. It assesses how fast you metabolize caffeine. If you're a slow metabolizer of caffeine, you should generally avoid caffeine. If you're a fast metabolizer, it usually has a neutral response on your cardiovascular health. What is the scope of my practice? Somebody's new to me. Well, welcome. They said they know I'm a cardiologist. That is indeed true. So I completed my initial medical training back in 2005 as a internist. I was in the military for 4 years, active duty, taking care of Marine recruits and retirees. So general internal medicine practice for 4 years. Went back and did 3 years of cardiovascular fellowship and been out in private practice for cardiology since 2012. So I mostly focus on the early detection of atherosclerosis, basically plaque in your arteries, and I help people not have heart attacks and strokes. I still do some electrophysiology, but that is not my area of focus. So if you have AFib, I will help potentially with it, but if you're thinking about antiarrhythmic therapies or ablations, I'm not the guy for that. So mostly if you have lipid issues, blood pressure issues, plaque in your arteries, that's what I tend to focus on for my patients. The utility of a CAC score in a patient with a history of a cath due to CAD without stenting. So if they did an invasive angiogram / cath and saw that you had non-obstructive coronary disease, there's really no use case for having a calcium score at that point. You've already defined yourself that you're somebody who is more than just primordial risk reduction. So a little bit of a definition, maybe a little bit different than what you would normally think about. But secondary prevention is you've already had a heart attack, stroke, stents, bypass surgery, and you're trying not to have another one of those. Primary prevention usually is classified as somebody who's never had a cardiovascular event and you're trying to prevent them from having their first event. But there's actually something I would consider as primordial prevention. You have no plaque in your arteries, and the goal is not to develop plaque. However, if you live long enough, you almost always will develop some degree of plaque. You just want that to be as late as possible in life and be asymptomatic for your entire life. So doing tests that looks for plaque early in life helps you determine, are you still truly low risk, or are you stepping into that intermediate or higher risk category? If you have plaque in your arteries, calcium score test, that's what you would figure out is that you have plaque in your arteries. So no real use case for a CAC score if you already have known coronary disease. If you're wanting to know, is the plaque getting better? Generally a combination of a CIMT, looking at your carotid arteries, and then considering a CT cornea angiogram, possibly with AI interpretation with a clearly to assess the plaque volume. I've definitely seen plaque volumes shrinking when you do serial clearly scans. I've been using HeartMath for a while and I'm getting good scores, but I don't understand coherence. So your heart and brain have a two-way kind of highway on being able to send messages to. There's actually more signals from the heart to the brain than there is from the brain to the heart. Cardiac coherence is assessing your heart rate variability, which is a metric of instantaneous stress. So when you're doing the breathing exercises, you're putting your heart and brain into coherence. Next question up tonight. How to increase metabolism for weight loss? Well, it's going to depend a little bit on how healthy your mitochondria are. Where do you live in the world? What season is it? How much light exposure are you getting exposed to? Your metabolism is instantaneously driven by the light that you decide to live under. So are you getting artificial light at the wrong times? Not protecting your eyes with blue blockers at night? Are you eating at night? Those are big things that will have an effect on your metabolism. Does alpha lipoic acid help? Generally only if you have diabetes. But another thing, back to your metabolic question, it's again one of those kind of test don't guess type of situations. I've had a couple different DEXA scans. They'll look at body fat composition, but also do the VO2 max and the resting metabolic rate card. They put a gas mask over your face and capture your expired carbon dioxide, and they can assess what is your resting metabolic rate. That will determine how many calories you need to eat to maintain your current weight. Some people are faster metabolizers, some people are slow. That will give you an idea of exactly how many calories you should be shooting for if you don't want to change weight. Question. Somebody has a high-risk CT coronary calcium score, 493. Do they need to take a statin? And they gave some lipid numbers. Looks like just an LDL cholesterol of 122. They say size, which size doesn't matter as much as particle number does. But then they do give ApoB of 95, which puts you close to the 50th percentile. Once you have a high-risk calcium score test, you typically want to be in less than the 20th percentile on your ApoB particles. So an ApoB target of 70 would be to start. The aggressive goal would be an ApoB of 55. Statins are just one of those tools. So 4 classes of medicines that have outcome data, meaning if people take these medicines, they tend to have less cardiovascular events. Statins are one of them. PCSK9 inhibitors, ezetimibe, and Nexletol, which is also known as bempedoic acid. Those 4 classes of medications. So if the person cannot tolerate a statin or ultimately decides that they prefer not to take one, there's 3 other classes of medications that can potentially help you get to your ApoB targets. I often have this conversation. I had one earlier today with somebody. If you're wanting to work on lifestyle interventions, you maybe only want to do that for 2 or 3 months. And if your numbers are not at goal, then really consider which pharmaceutical agent you'd be open to taking to get you down to your ApoB targets to lower your risk of developing further plaque. When the person sits down, their blood pressure is usually high, but by the 3rd or 4th time, it's generally normal. And when they go to the doctor, it's 180 over 100, sometimes higher, white coat syndrome. So very common situation. So this can be somewhat of a, quote, stress-induced hypertension. Your blood pressure should consistently be less than 120 over 80 at all times. If it's high just when you're at the physician, then you need to potentially think about doing a 24-hour ambulatory blood pressure monitor to see, are you having spikes in your blood pressure at other times of the day, particularly while you sleep. Your blood pressure while you sleep should drop at least 10 to 15% with the systolic number. You do want to have your blood pressure, monitored after 5 minutes of resting, so you don't want to be doing exercise or anything right before you check your blood pressure. Feet on the ground, back supported, arm at heart level, and have an appropriate sized bicep cuff. But a 24-hour blood pressure monitor gives you much more details about do you truly have white coat hypertension or not. Because just having white coat hypertension also increases cardiovascular events. What could a really pulsating jugular be? It could be due to congestive heart failure. It could be due to a pericardial effusion. There's a lot of reasons why the jugular veins might be distended, but it would take a physical exam to listen to other findings. Do you have clear lungs? Do you have an S3, S4? Do you have other murmurs? Do you have other signs of heart failure on exam? In some people, it's just a normal finding. So it depends on if you're having other symptoms or any other signs on exam. What is the mechanism by which N1O1 increases plasma nitric oxide? It's when it dissolves in the mouth, the actual nitric oxide gas is released. And then when you swallow the product, it does have some precursors that help endothelial nitric oxide synthase work better at converting arginine to citrulline. is there an objective way to determine if arteriosol is improving one's glycocalyx? I don't know what you mean by objective. The only way to directly look at the glycocalyx is with a microscope. So there is a device called the glycocalyx. Top of my head, it escapes me the name. I think it's a Glycocalyx Pro might be the name of the company that makes the device. Glycotek is the name of the device. So that's why we can actually visualize the glycocalyx in a live person. But the downstream effects would be looking at, do you have normal blood pressure, less than 120/80, pulse wave velocity testing, do you have elastic arteries? There's home devices. The iHeart can kind of give you the pulse wave velocity. I've done the bio strap as well. The Oura Ring gives you a version of pulse wave velocity. In my office, the endopath scan can tell you how much nitric oxide gets released in your arteries when there's a occlusion in your artery for 5 minutes. Blood test, indirect, but urine microalbumin creatinine should be normal. Uric acid should be less than 6. Homocysteine should be less than 8. Asymmetric dimethylarginine should be less than 100. Those often tell you that you have an improving glycocalyx if it was disrupted before. All right. Somebody says that they were diagnosed with AFib last year, just had an ablation. Their sleep was being affected, and their testosterone dropped from over 800 to in the 500s. They gained weight. So what should they look at? Sleep is getting back on track. Hormones are directly affected by your light environments and your sleep. So if you're not getting morning light in your eyes, the brain doesn't get the signal to release testosterone. Then you have to do strength training to stimulate the muscles to give you this impetus to make more testosterone. You have to eat a reasonable diet, so don't be undernourished. And then you have to get 7.5 to 8 hours of good quality sleep. So if your sleep's on par, great. Are you doing resistance training 2-3 times a week? Great. If you're doing all those things and you're still not controlled, check your light environment first. Somebody's asking, what are my thoughts on the urolithin A supplement as a complement to arterosil? They're completely different classes. So arterosil is a glycocalyx promoter. So if you have vascular disease, arterosil is often utilized. Urolithin A is to support mitochondrial function. Interesting data on urolithin A, but it depends on two things. I call it your supplement budget. So one, what is the amount of money you would be willing to spend a month on supplements? And two, how many pills are you willing to essentially swallow or choke down a day? Everybody has a limit on both of those. Urolithin A has some good data behind it, but it is not an inexpensive supplement. So you're going to be probably spending over $100 a month to take that one. So if you have a mitochondrial disorder, likely would be beneficial. If you're just taking it for general well-being, I'm not going to tell you how to spend your money, but it's, can you tolerate the number of supplements that you're taking a day? If it's not overly bothersome, I haven't seen any negative effects of urolithin A. So somebody was asking another question, is there any other way to tell if arterosil is working? Those were the things I mentioned in the other person's comment. The other thing you look at is if you've had a CIMT, an endopath, a clearly CT angiogram, and you've been on arterosil for at least 6 months. If you repeat the image, usually you're not repeating it in a year. I'm sorry, in 6 months, usually it's a year. You often will see regression of plaque. So if plaque's getting better, then you know it's working. But I have seen people with arterosil, sometimes if the plaque is getting better, sometimes they cut down the dose to half dose, even though that's not normally been studied. You just be your own biohacker, do your own test. If you fix what your glycocalyx was getting damaged from, maybe you don't need the arterosil twice a day and you can cut down on the dosing. But if your arteries start getting stiffer, blood pressure goes up, other things getting worse, probably want to go back up to the studied dose, 1 tab twice a day. I'm just checking out the comments. I think there's just some other ones that are kind of duplicates. Just talking about the white coat hypertension. Seeing some familiar faces in here, so they're good. You like these glasses? All right, so these are some of the new EMR Tek's clear frames. I'm not so sure about the size for my face shape, but gonna try them out. I like the intensity of the lens. They're very clear. All right, next question. Somebody says they're 35, live a healthy lifestyle, but got, looks like an ApoB of 108, and can tell if this is possibly lipoprotein A, 220. Cholesterol's over 300 some odd. So what do you suggest? Those lab values are in the range of familial hyperlipidemia, at least on the total cholesterol component. So potentially would repeat it and see, do they still show the same? If so, genetic testing may be useful to figure out, are you somebody who has a gene abnormality for ApoB, a gene abnormality for the LDL receptor, PCSK9 enzyme? Why do you have high lipoproteins? I will often check the Boston Heart Lab for these patients. There's a test called the cholesterol balance test, which will tell you if you're a hyperproducer of sterols. So is this becoming because your liver is producing a lot of lanthosterone desmosterol and thus cholesterol? Or is it an issue with your intestines reabsorbing beta-cytosterol or composterol? If that's the case, then medication like ezetimibe tends to work well for those patients. GB Insight is the lab company that we tend to use to look for the genetic abnormalities for lipids. And then, lipids are just one part of the story. I want to know what the health of the glycocalyx and underlying endothelium is, how much oxidative stress and inflammation you have. If you have a lot of oxidative stress inflammation and you have evidence of endothelial dysfunction, having this type of lipid profile may accelerate atherosclerosis progression. So you would start to want to look at testing that looks at the health of the arteries. Things like the endopat scan, carotid endomorphic medial thickness scans, and even a calcium score at this age. And if those are abnormal, then you definitely want to start, considering some type of treatment to modulate the lipoproteins. All right, so I think I got through all the live and comment questions. I'll hang out for a few minutes to let any other questions filter in while waiting for that. I sent out an email last week. I'll probably send out another email this week with some updates about Apollo Cardiology, my practice in St. Louis, where I focus on the early detection of vascular disease, helping people not have heart attacks and strokes. I still have availability if patients want to work with us one-on-one. It's getting a little bit more limited. I am booking out at least 2 months into the future to do deep dives where we, spend 3-4 hours with you really figuring out what's going on with your vascular health. But if you're interested in that, if you go to my website, drtwyman.com, there's an application, and one of my team members will reach out to you and talk to you about the details. There is a health cardiology summit coming up at the end of the month that I was invited on to do an interview with Dr. Jack Wolfson. He's the paleocardiologist. If you got the email last week, the details to sign up for that summit were in there. The summit, generally the way that these work, they're over a couple-day period. There's going to be multiple lectures released a day. For the most part, in these summits, if you watch the video that day, there's usually no charge to sign up for the summit. But if you want to watch the videos at a later date or save the videos, there's usually kind of a nominal charge to be able to have access to the videos for a lifetime. So if you're interested in that, I'll be sharing some of the links in my stories over the next couple weeks. And then if you're on my newsletter, you'll get a kind of a reminder later this week on that. All right, and so somebody's asking about remote work. So at this time, the medical legal laws are that I need a medical license in the state that I'm physically located and where the patient is physically located. So I do have some licenses in various states. Top of my head, it's Missouri, Illinois, Kentucky, Texas, New York, Florida, and there There may be one other if I remember real quick. But it's always a big process trying to get credentialed in every state. It's multiple hours of paperwork, interviews, hundreds if not thousands of dollars to get licensed in each state. So it's a big process. And so to be able to work with the majority of patients, I mostly do a lot of this kind of free, kind of informational kind of sessions, either through Instagram or the podcast or YouTube, so people can learn about what tests they should consider to get testing for their vascular health. But if they're asking for me to be able to order it, I need the person to be sitting in front of me to be able to legally do that. So I have many patients I can see logging on tonight that have made that trip into St. Louis. You come in, you spend a few hours with us. We can then get you all the testing you can need for your vascular health that day. Any blood work we can send out from our office. We have our medical assistants are outstanding, phlebotomist. So it's kind of a one-stop shop for your vascular health. A lot of the testing takes 2 to 3 weeks to result. And then when all the testing results are in, then the follow-up visit can be done via telemedicine. And sometimes patients, that's all they want is they kind of this deep dive, they get all the information, and then they go back and work with their local primary care doctor or local cardiologist. But if they're asking us to continue to work with them, we can for that first year, usually 4 to 6 months after their first visit. We'll do a kind of a touch-up visit via Zoom. But if the patient wants to work with us and have us prescribing any medications or making changes to supplements or ordering labs, then generally every 12 to 18 months, the patients come back to St. Louis for retesting. All right, guys. Well, those are some great questions tonight. As always, I appreciate your time and attention. I will download this video. I'll run it through the AI filters, and I'll have it up on my YouTube channel, drtwyman.tv, and it'll usually be released within the week. So hope you guys have a great week, and I'll see you next Monday, 6 p.m. Central Time.